Okay, it's 3 o'clock. We're going to get started. Aaliyah and Cindy, can you hear me?
Yeah.
Yes, we can hear you.
Perfect. Okay, today's presentation on Hospice 101 will be given by Aaliyah Tooker and Cindy Searfoss from the Center for Hospice. I'm going to start with a little bio of each one. Aaliyah Tooker is the Community Education Coordinator at the Hospice Foundation and the My Hospice Ambassador for the state of Indiana. Aaliyah is a graduate of Indiana University South Bend, where she received degrees in both political science and psychology. Aaliyah has helped develop the Center for Education and Advanced Care Planning, as well as create end-of-life educational opportunities throughout the community. Aaliyah is involved in several community events, such as Death by Chocolate and Cupcakes to Die For. These events are designed to normalize the conversation about end of life. Aaliyah has also been involved with professional education programs such as the Hospice Foundation of America's webinar series, offered in partnership with St. Joe Health Systems. Aaliyah's goal is to continue to create lasting partnerships with organizations that help educate the community about end-of-life conversations and advanced care directives. As the My Hospice Ambassador, Aaliyah has met with legislators to advance conversation and bills related to hospice and palliative care nationally and for the state of Indiana. As a founding member of the Grassroots Initiative, Aaliyah has focused on creating lasting relationships with Indiana's local and legislative members. Aaliyah is a certified First Steps ACP facilitator through Honoring Choices and can assist healthy adults complete their advanced care planning documents. She has facilitated numerous conversations and filled out ACD documents for community members in Center for Hospice Care's 9-county service area. Cindy, in her role as Partnership Director for Global Partners in Care, she has helped develop strong bonds and collaborations among organizations throughout the world to enhance access to palliative care in low-resource settings. Her career has included stints as the managing partner of an advertising agency, director of creative services for a publishing firm, director of alumni services at IU South Bend, and director of advancement for the Stanley Clark School. She received a bachelor's degree from Indiana University in journalism and a master's degree in creative writing from the University of Notre Dame. She is a storyteller by inclination and training and has extensive experience in raising funds for worthwhile organizations through marketing, advertising, public relations, social media, events, and direct mail. She currently teaches professional writing as an adjunct instructor at St. Mary's of the Woods College and technical communications as a limited term lecturer at Purdue University. Okay, and then after the presentation, we'll have time to answer any questions you have. There's a question and answer box to the right, and you can type in your questions whenever you have them, and we'll answer them at the end of the presentation. So Aaliyah and Cindy, if you're ready, you guys can begin.
Sure, thank you. Thanks for having us here today. This is Cindy. Basically, I want to provide a little bit of context for what we're going to talk about today. Hospice and palliative care can be a very difficult conversation for healthy adults, let alone anyone who is facing an end-of-life, life-limiting illness. Our position on all of this is the more you know to help guide these conversations, the more you know about hospice and palliative care, the easier it is to make informed decisions that reduce the stress on those facing end-of-life situations, their caregivers, and professionals in the community who are assisting the family and loved ones go through these situations. So our role in all of this obviously is to make sure that we're educating the community about what hospice and palliative care can do. And certainly any questions that you have about what a hospice organization's role is in end of life, we'll be happy to answer at the end of the presentation. So Aaliyah, take it away.
All right, so what we're covering today is kind of the beginning idea of end of life and Hospice 101 conversations. Let me go ahead and move over here. So when people say hospice and palliative care, there's often a little bit of confusion about what does that mean. What's the difference between hospice? What's the difference between palliative care? So palliative care, the focus is to treat a person's symptoms from an illness and provide support to the patient and family. A major distinction with palliative care is that it can go along with their hospital stay care as well. So that's pain management, symptom management, while they may still be seeking curative care. And then within that, so palliative care provisions, you must have a progressive or incurable illness, limited life expectancy measured in months but not years, and a physician must order admission. So I don't know, Cindy, if you want to talk from your global perspective on palliative care.
So in many environments outside, in many countries outside the US, palliative care is used for anything from a patient who has cancer or some sort of other life-limiting condition, all the way through end of life. The US looks at, and we're going to dig deeper into this as we go through the presentation, hospice care in the US is set basically by the Medicare hospice benefit. And so that's where a physician has to certify that if the disease would take its normal course, the patient would have 6 months or less life expectancy. So using the term palliative care in the US takes this type of symptom management and pain control outside of that Medicare benefit. But in reality, hospice care is a subset of palliative care because, of course, both of them are looking at treating illness and symptom management. Hospice care is just within a particular window of time, the last 6 months of life.
And that's an important piece that really, focuses in on what hospice is, especially within the US when you look at the Medicare Part A benefit that would be paying for that. Now, that does not mean that within those 6 months, if you have not passed away, you're kicked out of hospice care. You would be recertified if the disease is following a normal course. So if you are still declining in health and your prognosis is still around 6 months, no doctor can, accurately determine exactly how long a patient is going to live, but they can look at the prognosis, see a decline in health, and with that normal progression would fit in that 6 months or less. We've had patients for years in hospice care, but they are still declining within their care here.
One of the things that's unique about hospice care in the United States in particular is that it's very patient and family focused. And it is not driven specifically by a physician and a physician alone. Hospice care puts around the patient and family a number of supporting disciplines and ways of making sure that the patient and family are cared for as a holistic unit. So we have physicians, spiritual counselors, also called chaplains, social workers, bereavement counselors, home health aides, therapists, nurses, and volunteers, a multidisciplinary team or an interdisciplinary team that works with the patient and family to make sure that every aspect of their lives is being supported as they face end of life.
And an important distinction with this is that when you're in a hospital setting and it's illness driven, it's illness focused, and then you move to a hospice setting, it really becomes that patient and family focus, a much more holistic focus of, what do you define as a good day? That's different for every individual. And, what is your feeling? What is your pain level? And when you take the focus away from the illness, that can help focus and bring in a lot of different areas in their life that they may enjoy and may have forgotten to enjoy while they were seeking treatment.
I think one of the key things to note also about hospice care is that in the US at least, it is the patient is no longer able to seek curative treatment. Mm-hmm. Palliative care can be given at the same time as curative treatment, but if a patient makes the choice to enter into hospice care, they are giving up the right to continue to seek curative treatment. There is one very important exception to that rule, however, and that is anyone 18 or under. Anyone 18 or under can undertake both hospice care and curative treatment at the same time. That rule changed within the last few years, and basically it means that parents don't have to decide, do I want to seek hospice care for my child or continue to seek curative care.
Mm-hmm. And another important distinction between what you might see in a hospital type of setting and curative care is that a lot of the care provided is in the patient's home. So whatever they may define as their home, whether that be their house, residence, extended care facility, group home, jails, homeless shelters, that all-encompassing idea of where are you either most comfortable or where you define home for yourself, that's where the care then focuses in at.
This chart provides some background about where hospice care takes place, what does it include, and who pays for it. So as we noted, it can be a home, an extended care facility, it can be a hospice house. Center for Hospice Care has 2 inpatient facilities that provide respite care for hospice patients and under our care. So for example, if a caregiver needs to go out of state for a wedding, that patient can be cared for on a respite basis in one of our hospice houses. It also is an inpatient unit to control pain and symptoms that may not be able to be controlled in an at-home situation. So patients can come here until those symptoms are managed more effectively and then go back home. We can provide hospice care in hospitals, and it is around-the-clock care 24/7. Hospice care also provides that interdisciplinary team that we talked about. So part of the hospice care program is access to home health care aides for perhaps bathing or other personal care, is social workers to help with legal aspects of end of life, etc., and also spiritual care, as well as bereavement. The hospice benefit also includes direct medical equipment. So those could be hospital beds, it could be a walker, whatever is necessary to provide quality of living for that patient. It also takes care of supplies, medications, anything that's directly related to the reason, the illness, the condition that patient is in hospice care. Now, for example, if you have a patient who's in an extended care facility and the diagnosis that has put them in hospice care is cancer, and yet they also happen to be diabetic, the insulin or other supplies related to the diabetes are not covered by the hospice benefit. And again, all of this is supplied 24/7. Hospice care comes under the Medicare benefit, it is under the Medicaid benefit. Most private insurance programs cover hospice care. We have self-pay patients who take care of any bills themselves. And again, all of this is around the clock. As I noted, we are the only hospice program in our service area, which is 9 counties here in northern Indiana, to operate Medicare certified hospice inpatient units. We have a 7-bed unit in Elkhart, and in February we will be opening a 12-bed unit in Mishawaka on our Mishawaka campus.
Another important piece to mention as well is that if you have cancer and you are in hospice and you fall and you break your arm, that is, you're not limited to you can never go to the hospital. You just cannot seek curative care for the thing, that cancer that you were in hospice for. But by all means, you break your arm, you can go seek medical care for your arm as well. And one thing that we'll see often is that, we want people to call us first, because when they're so used to going to the hospital, the emergency room, 2-3 times a week, say it's for COPD or, symptom management, essentially, that they're going to the hospital or the emergency room multiple times a week or month, it can be a drastic change for them to stay at home and see their loved one go through different phases and get the symptom management taken care of at home. So we try our best to work with the families and their understanding that this is a transition not only for the patient, but the caregivers themselves as well.
So a little bit about hospice in general, just as some background. Although it has its roots back in the Middle Ages, hospices were part of what the Crusaders was part of their life way back when. In the U.S., hospice has only been around since 1980 in most cases. We as an organization were chartered in 1978, and we saw our first patient in 1980. So we've only been around as a medical care specialty for about 40 years. However, it is the fastest growing part of Medicare. A lot of that has to do with the demographics in the U.S. right now, which is the baby boomer generation is getting older, and obviously, as they age, hospice care becomes more of a reality.
Yes, we have about 10,000 baby boomers a day turning 65, so the age of retirement. So a lot of even medical journals are looking towards the future and the future of hospice and how it's going to grow and the vital importance that it has in communities, bringing family members together and really keeping that symptom management.
Yeah, so you can see from some of these statistics, from one program in 1974 to 6,500 hospices today, there is a tremendous amount of growth in this industry. And just the fact that more people are learning about the benefits of hospice care at the end of life. So you can see it's more than doubled since 2013, how many people have received hospice care under the Medicare benefit. Just a quick graph here that shows the number of patients served in the visual. This continues to grow, and we anticipate both here in our area as well as throughout the country that the need for hospice services will continue to expand.
It is something that we're seeing essentially we're going back to the basics of what is the patient's needs, and that family-focused and patient-focused ideology is something that as individuals in our communities learn about it, they want that. And that trend is not going to stop, especially with the baby boomer generation and, larger generations behind that as well.
So just, again, some of the statistics about the growth of hospice care. So NHPCO is our governing organization, the National Hospice and Palliative Care Organization. Approximately 49% of the deaths in 2014 were under the care of hospice. And again, we expect to see this grow as more people become aware of or have had an experience in their family of what hospice care can do. And part of this is also the benefits that people see with what comes with hospice care. One of the things that we found is that patients who receive hospice care actually live longer on average than those who do not receive hospice care. For some, for some people, this seems a little contradictory. I actually went into an extended care facility once to give a presentation and overheard two women who did not know who I was say, one of them told the other one, oh my gosh, those hospice people are coming. everyone I know who's gone into hospice has died, which is actually why you enter into hospice. But the perception is that you enter hospice and you die immediately. Most of the time, what we see is that if people enter into hospice care earlier in their last 6 months of life, that receiving pain and symptom management, as well as knowing that their loved ones are receiving support throughout this caretaking journey, does relieve stress. It relieves stress physically for them. It relieves stress emotionally. And so that's why they do tend to live longer, at least according to the studies that we've seen.
And I think that this is something that makes a lot of sense when you think about the stress that can be put on the body when you're going through curative treatments, or you are in a hospital setting where you're unfamiliar with the area. You look at one of the top 5 stressors is moving. And, you know, if you feel that your home is essentially moved into a hospital, that puts a lot of strain and stress on the body, along with medical treatments. And I think that as the US's ideology is shifting back to looking at the body and looking at the individual as this holistic person, that care goes beyond just medical treatment. It goes into, you know, their social standing with family members, with even coworkers, or, you know, their community members, experiencing nature, being able to get out in whatever capacity they can, and enjoying some of the small things that they can do in that time versus being focused on the next medical treatment.
Another study among patients with non-small cell lung cancer who received palliative care lived almost 2 months longer than those who received standard care. My understanding of this study was that the palliative care was walking hand in hand with the curative treatment at that point. And so this is what you tend to see, particularly in overseas settings, is palliative care along with curative treatment. Unfortunately, right now, that's not the standard of care that we have in the U.S. But I think as more studies are being done on this, you may see some of this care landscape changing. One of the things that is indicative of hospice care and palliative care, regardless of the setting or the country, is that it is about improving the quality of living. And quality of living, as Aaliyah had noted earlier, varies from patient to patient. And that's why having an interdisciplinary team around the patient to help them determine what it is that means the most to them and how do they navigate this end of life journey, the end result of that is a better quality of life for the patient and reduced stress for them, for their family, and usually a more peaceful time at end of life. So certainly one of the things that we like to make sure that people understand about hospice care is that it's very accessible for patients and their families. Most of the time it is paid for by an outside source, whether it's Medicare, Medicaid, private insurance. We are a nonprofit organization, as are other hospice organizations in Indiana and throughout the country. We in particular have what we call a very generous sliding scale based on the patient's ability to pay. And that can range from anything from a few dollars to $0. So we don't want people to ever think that, I can't afford hospice care, or a family to think, I don't know how we're going to pay for this. It saves taxpayers money in the long run because people are not being readmitted consistently into curative programs, whether it's through the emergency room, as Aaliyah had noted earlier, or for other types of treatments that become very invasive and very expensive.
Yeah, which is, what makes hospice a wonderfully bipartisan option for a lot of people, and especially in the U.S. It's there's so many wonderful things that are happening with hospice as this movement is going forward and growing that everyone can agree on, which is always good.
So here are some of the things that are challenges for us in delivering hospice care. Even though this benefit is intended for someone who has a life expectancy of up to 6 months, the average length of stay is less than 70 days. And in some cases, it's much shorter than that. We unfortunately sometimes have patients admitted within hours of having a phone call, and they pass away within a couple of days. That's very difficult on the patient's family a lot of times. And so we encourage anyone who thinks that they may be either they or a loved one in an end of life situation to call and talk to one of our referral specialists, as quickly as possible. If the physician says, no, you're not within that 6-month window, at least the patient has started to explore those options. One of the other things about hospice care is that it does not have to be referred by a physician. A patient can self-refer, a loved one can refer, a friend or family member can refer. It does not have to be driven by a medical provider.
Yeah, and again, kind of going along that same line of what Cindy was saying, that life expectancy of up to 6 months and the underutilization of hospice can be seen on a multi-tier level of, things that are currently being looked at in the Senate as far as an Education and Training Act that would help physicians who are so wonderful at saving lives be able to take a step back and say, there is a certain point where I can no longer save someone's life. At what point should I introduce hospice? And maybe that's earlier than what I initially thought. Or, hospice is this side note to them, and let's introduce it earlier. Let's give our patients this option as well. And then community education, a lot of what we're doing to be able to tell people that, this is something that you can ask about as well. This is something that you have control over, in the sense of asking questions, talking to your physician about it, advanced care directives, choosing what you would want towards the end of your life for yourself or what a loved one might want as well.
And as we noted, one of the most difficult things, knowing what a hospice benefit can do for patients who access hospice care earlier in that 6-month window, is having almost 40% of all hospice patient admissions die in 7 days or less. Again, it's very difficult for family members in particular, and also knowing that a lot more could be done to help enhance that quality of living towards the end of life.
Yeah, oftentimes with pain management, having more than those 7 days is vital to help get their quality of life to pain-free as possible. So the sooner that they can be introduced to the idea of hospice or transitioned over, the better for their own symptom management and for the family to be able to cope with that as well.
There are some really common myths about hospice. And so one of the things that we do educationally is try and make sure that people have, some of the basic talking points, what hospice can do, and why it's important. One of the myths is that it's primarily for cancer patients. And typically when hospice was first undertaken in this country, most of the patients that were seen in hospice were cancer patients. Currently, some of our most significant percentages of patients are those with pulmonary conditions or congestive heart failure. Cancer is still obviously a diagnosis that many hospice patients have, but it's tending downward, while pulmonary and congestive heart failure are, as well as dementia and Alzheimer's, are increasing. Another myth is that hospice is a place. And while we do have offices and we have inpatient units, hospice is really a type of care. It's not a physical location. And as we noted earlier in the presentation, hospice care can be provided anywhere where the patient calls home.
And then something that Cindy had mentioned earlier, patients must be referred by their doctor. That is not something that is true. Oftentimes, especially with the community education that we do, we encourage you and your loved ones to talk to your doctor about hospice or end of life care in general, and ask questions and have the information so that you're not waiting for your doctor to introduce it. You really are in charge of that side of your health care.
One of the other things that people sometimes are afraid of is that if you choose to go into hospice care, that you have to give up your primary care physician, and that's not the case. We have physicians on staff, and they will work hand in hand with your primary care physician. Certainly, if you'd want one of the hospice physicians, if the patient would want strictly to see one of the hospice physicians, that's certainly fine. But most people do choose to stay with their primary physician as well. When hospice organizations started 40 years ago, they were staffed primarily by volunteers. Currently, Center for Hospice Care has a paid staff of 230 people. Many of them are nurses. We also have home health aides, social workers, chaplains, bereavement staff, a whole host of people who are professionals and highly credentialed in hospice care and provision. We do have volunteers because actually hospice is the only medical program that does require a volunteer component to it. So we have approximately 500 volunteers in our service area who do help. They provide patient visits. They help here with things that we do as staff members as well. So we do have volunteers, but they are not the primary care providers. And I think one of the most important things that sometimes people don't understand about hospice is it is not meant to hasten death. Death in hospice occurs naturally on whatever time frame that particular human's time frame is. We neither seek to hasten it nor delay it. The idea of hospice is to walk with that patient and the family through whatever that patient's journey and time frame is. So there is nothing in hospice care that would be a non-natural death.
Mm-hmm. Yeah, and oftentimes based on the studies that we showed you before, when you really truly address, what someone's holistic needs are, whether that be the pain management side of things, or what they define as a good day, what they define as something that they enjoy that they haven't gotten to do since they started their curative treatment path, oftentimes that can help not prolong their life, but alleviate the pain so that they end up having better days while they are alive.
So here are some of the things that we find are challenges for end-of-life care access. Denial is one of the biggest ones. Sometimes it's the patient not wanting to see where they are in their life's journey. Sometimes it's family members who do not want to admit that their loved one is nearing the end of life. Sometimes it's with clinicians. Some physicians have a very difficult time admitting that they can no longer fix or address physical issues. Sometimes there's bad clinical record keeping. That does happen occasionally. A lot of times it's just lack of education and information about the benefits or what hospice care can do.
Yeah, and then, not wanting to have that conversation at all, whether that's a conversation with yourself that, this is maybe time for me to look at another option, or, you know, a conversation with a loved one. It can be extremely intimidating to talk to a loved one about the possibility of end of life in any capacity. And so a lot of the education and information that we try to provide is, you know, essentially saying the earlier the better to introduce this idea. You know, at 18 and 19, we are not invincible. And as we get older, we don't know when our end of life will be. And that's not meant to intimidate, but is meant to help spark that conversation that, you know, while we're here and while we have our sound mind, let's address what our wants are and what our needs are for our own end of life care or for a loved one's end of life care, and whether that would include hospice, so that if you're ever in a situation where you're not able to speak for yourself, a family member isn't making that decision for you. They are making that decision based on what you've wanted for yourself.
And that's one of the important things about by making sure that every adult has a healthcare proxy. The state of Indiana calls it a healthcare representative, and that is the person then that's been chosen to make sure that these advanced directives are being followed at end of life, or if the person is in a situation where they can no longer or cannot communicate for themselves what their wishes are.
And this is an important piece, is to make sure that individuals know that this is not the same thing as someone who's a representative over your finances, that this is a different document. This is over your health care. That's a question I get a lot of. Oh, well, I have someone who's in charge of my estate. That's wonderful, but who's in charge of your health care?
And one of the things that, you know, certainly is a cultural aspect of end of life in the U.S. is this idea of giving up. If you've ever read the obituary of somebody who valiantly fought to the end against cancer, sometimes it's not necessarily a matter of giving up. It's a matter of recognizing that quality of life and battling are not necessarily the same thing. I know I've had personal situations with friends or family members who did not necessarily take into account how difficult end of life could be, and not plan for it appropriately because they were afraid of giving up. And giving up doesn't necessarily mean that you can't have a good quality of life. It's basically assuring that you have the end of life that you want. We do have a couple of specialty programs we'd like to mention. These are, again, pain and symptom management programs that we do, and have seen tremendous results, particularly in patients no longer having to access emergency medical care, and also just extending the quality of life and enhancing their quality of life. One is called HeartWise, and it's our program for congestive heart failure. And again, it's managed by our hospice staff, and they work closely with patients and their loved ones to manage the symptoms of this condition. The other one is our program for COPD, which is called Breathe Easy. It operates again under the same principles, where we have our clinical staff working with patients and families to manage COPD symptoms. We also have a specialized program for our dementia care program, which offers specialized care for patients with late-stage dementia. We also have a palliative care outpatient center. Physicians can refer patients who may either be having multiple conditions that are giving them difficulty with symptom and pain, or it could be someone who's on the trajectory for hospice care but not quite there yet, and would like to look at how these symptoms can be managed to lengthen that trajectory. Just a few things locally about CHC. So we served 27 patients in 1980 to more than 2,045 in 2018, which is the last year right now that we have statistics for. Our average daily census was 4 in 1980. It was 294 in 2018. We serve 9 counties today, and we have 4 care offices in northern Indiana, as well as a freestanding campus here in Mishawaka. We recently added Milton Adult Day Services to our care, and we also manage an international partnership agency. One of the things that we do like to make sure that everyone is aware of is we provide services without any regard to age, gender, race, religion, disability, sexual orientation, diagnosis, or ability to pay for our services. As I noted earlier, we have a very, very generous sliding fee scales. We have never turned anyone away because they were unable to pay for our services.
And beyond that, jumping in about our bereavement services in particular, that's something that we like to highlight because without an association to Center for Hospice Care, those bereavement services are still open to the community, regardless of any type of connection with Center for Hospice Care. So one of the programs that our bereavement department has is with children. It's called Camp Evergreen, and we just completed our 26th or 27th year, 26th year. And so Camp Evergreen essentially looks at how does grief affect those that are 18 and younger, as long as they're still in high school, and how can we address grief for that age group in a different, more specialized way for them, whether that, you know, the death or that loss is something, you know, it's their favorite football coach and or a loved one that they knew.
Yeah, so as Aaliyah noted, all of our grief and bereavement services are provided at no charge to the community. We also have a program called After Images, which is an art counseling program that helps people who have a difficult time talking about grief, work through what they're experiencing with art. And that's provided here on our Mishawaka campus as well.
Yeah, both those programs I think are so important to highlight for our community because it's something that really extends beyond hospice and really connects anyone who has had a loss of any kind in their life. So now I think we'd like to open it up for some questions. Kayla, I think you mentioned that you would see questions on your side.
Yeah, I'm going to give them a few minutes to type them in. I don't see any currently, but we'll give them a couple minutes.
Sure. Well, as we wait, yeah, any type of questions regarding hospice. I know we covered a lot today. There's so much to cover within hospice, whether that's its history and or, you know, how we see it today. And especially in our community, it really has grown so much, and Center for Hospice Care has been such a part of each community that it's been in, whether that's our Roseland campus that we've had, or our Elkhart facility that's, you know, beautiful, and now our Mishawaka campus as well.
Okay, we do have one question that came in. It says, can you clarify what is the difference between hospice and palliative care?
So palliative care is treatment of pain and symptoms that is not within the last 6 months of life. So anyone who's experiencing pain and symptoms due to a life-limiting condition, some examples of that would be MS, it could be Parkinson's, it could be ALS, it could be COPD, it could be congestive heart failure. Those are just a few examples. Anybody who's having pain and symptom difficulties in that would be a good candidate for palliative care. Hospice care is a subset of palliative care that is offered within the last 6 months of life. Basically, it's certified that if by a hospice or palliative care physician, that if that patient's diagnosis, they would be looking at a life expectancy of 6 months or less.
Mhm.
As Aaliyah noted, sometimes with pain and symptom management, people do live longer. And so after that 6 months, the patient would then need to be recertified by a hospice and palliative care physician.
But as long as they are continuing to decline, and that can be, shown in a multitude of ways, but as long as there is a decline in their health, they would be recertified within that, because as I noted, as much as we would like to know the exact day and time that we might pass, a physician nor any of us individually will be able to determine that. So it really is in the physician's best, knowledge of the disease and the progression that they're seeing in that specific patient.
Thank you. They said they appreciate the clarification. We have a couple more. They want to know what counties are covered by Center for Hospice.
Okay, so we are in our St. Joe, Elkhart, Marshall, Kosciuszko, LaGrange, LaPorte, Porter, Stark, and which one am I forgetting? Fulton.
Yeah, Fulton.
Yeah. Those are the counties currently covered by Center for Hospice Care.
Thank you. And there's another one. It said you spoke about keeping someone alive as long as possible. What about the person that does not want to live and is ready to die?
I think what Cindy had mentioned with that, keeping someone as alive as long as possible, was that that is not what we do. Essentially, we're not seeking any type of curative care, and that's what a hospital would be seeking to do. The studies that were show that when someone has their pain management under control, the days that they do live tend to be more fulfilling for themselves. They tend to feel better in whatever capacity that means, and their life expectancy may be longer than when they're in the hospital seeking curative care. That is not a black and white statement of yes or no, it is. And it is important to note that we are not seeking to extend anyone's life. And oftentimes people do reach that point of, I have been in a hospital 3 times this week. Is this something I would like to continue to do every week until this curative care, which is not working, and I have that diagnosis of 6 months or less, just ends? Or do I want to look at another option? And that is completely up to the patient and whatever they see fit for their end of life care, which is why we try to introduce some of these conversations early.
Yeah. I just want to see if was that question aimed at assisted suicide or death? Do you know? Because
they didn't clarify. Jean, can you clarify? I'll see if she can type in to clarify.
Yeah. Because that certainly is a very heated topic right now, and the stance that hospice organizations right now in the U.S. have taken, and this includes us, is that hospice does not prolong life, nor does it shorten life. It is about us walking beside whatever that patient's natural lifespan is. I know there has been a lot of talk about end of life in general and patient self-determination, and that is an area that hospices right now have chosen to remain out of those conversations, and I don't see that changing in Indiana, at least right now. Mm-hmm. If that's where that question was going, and that
would go, yes, if it was talking more about PASS or physician assisted suicide, I think that would lean more on the hospitals and situations in which a physician would be helping determine mental state, things like that. It becomes a very, very loaded conversation.
Right. And the hospice industry as a whole has tried to stay out of that for a lot of different reasons.
Mm-hmm.
Okay, yeah, she typed back and said, just wondering if a person wants to die, how do you support them in hospice? Like, how do you support their decision?
Oh, well, I think there's a lot of ways. If someone has chosen to not continue curative care, oftentimes at the recommendation of their physician or family members, or pure exhaustion of themselves, and that's the decision that they've made. I think one of the main words that I really try to bring to mind and bring to the mind of the people that I'm talking with is mindfulness, and that while that decision may not be what you yourself would decide, we need to be mindful and respectful of others who are making the decision for their own health care and their own bodily autonomy that they have for themselves.
Yeah, and I think it comes down to, again, as a hospice organization, we are there to provide pain and symptom management and support for the patient and their loved ones. Again, we wouldn't do anything that would hasten their death, but we wouldn't prolong their life either. Typically, when a patient is reaching the very end of life, they know that it's coming. A lot of times that their family does as well. Our professional clinicians are there to help support them in whatever, the family and the patient, in whatever way is most appropriate. It could be again, helping with whatever pain or symptoms that they're experiencing.
It could also be, spiritual care. We are non-denominational, and so spiritual care becomes this broad conversation of whatever that individual really identifies with or wants to discuss. And a lot of that conversation with a patient can lead over to conversations with a family member, and the support that we offer the family members to allow them to say, I'm not sure how I'm handling my loved one passing. We have bereavement services for that reason. That is a very normal part of losing a loved one, is going through that process of, well, I'm not accepting it quite yet, or any of the emotions that go behind that, those 5 stages of grief. And we really try to provide those bereavement services for that particular reason, whether it's, again, a child's favorite football coach who really made an impact on their life and they're not sure how to address that, or a family member who's not ready to see their loved one go into hospice. We try to help with some of those guided conversations.
Did that answer the question?
I believe so. Jean, if you can clarify if that answers your question. Yep, perfect. And I see one more question we have. Can you provide information about respite available for families?
Sure. It would be, that's only available for our patients who are in our care. And so if it is someone who has entered our care as a hospice patient, their patient care manager would be able to arrange that.
Perfect. Does anyone else have any other questions? Okay, I'm not seeing any more come in. Aaliyah and Cindy, if they seem to come in at the end, would it be okay if I email them to you?
Oh, certainly. Yeah.
Okay.
I'd be happy to. Yeah, great.
Perfect. Thanks so much. If you're an Advocacy Link employee, you'll automatically get credit. If you are not, you'll get an email shortly that confirms your attendance. And there's no more questions. So again, thank you, Aaliyah and Cindy, for the presentation and wonderful information. And then you both will be giving a presentation, I believe, in a few months for us. So we look forward to that.
Yeah, we look forward to it.
All right. Thanks so much.
Yep.
Bye.
Bye.